As I say, I am one of the consultant obstetricians. I'm a lead for maternal medicine. So I look after a lot of women who have blood pressure issues in pregnancy. For this brief, I was asked to consider and talk to you about pre-eclampsia, specifically during birth, which is quite an interesting topic because it's quite, in a way, narrow, however, extremely broad, because the birth of somebody with pre-eclampsia can vary from somebody at 28 weeks having an emergency cesarean in the middle of the night to somebody who is 41 weeks who just has a touch of blood pressure but has a diagnosis of pre-eclampsia. So what I have tried to do is to consider women who are labouring and all the different points which we need to consider as labour continues. And what I've kind of put out is a set of points to try and consider all the different things that we do need to have in the back of our heads when we're looking after women, particularly when they're trying for a vaginal birth. So I've put them into a number of categories. So we need to consider their blood pressure management. Fluid balance is absolutely vital for women with preeclampsia during birth. And I'm going to come to that in a little bit more detail. We obviously need to watch for the complications. Sue mentioned eclampsia, but also HELP syndrome. Are they developing acute kidney injury? Is something else deteriorating with their preeclampsia? Obviously, we're considering maternal and fetal well-being. How are they coping? How are they coping with labour? I'm going to talk a little bit about second stage management, and I'll talk about third stage management and a little bit about after the baby is born, but Layla is going to cover most of that. So what do we need to consider? We need ideally to consider women who have preeclampsia in labour. These are high risk births. And ideally, we need somebody, a midwife, who ideally has HDU training, but I know that's relatively rare. But obviously you need somebody who's having one-to-one care, and they are going to have more input, more medical input. And so there's going to be a whole lot of things to consider as you're looking after them. Obviously, in labour, we do regular observations. That is in general for everybody. However, people with preeclampsia will often need more intensive regular monitoring, regular observations with oxygen levels, blood pressure, pulse, temperature, but also what is their urine output doing? How are their reflexes doing if they are on magnesium? The ideal is they should be in an obstetric-led unit with access to theatres, because the trouble with preeclampsia is it can deteriorate extremely quickly, and some people will need very fast intervention. Ideally, we need anaesthetic input because these women may need their help and may even need to go to a more critical care setting, an HDU setting, an ITU setting if severe complications arise. So, thinking about blood pressure, what do we need to do? We're aiming for a blood pressure of less than 140/90 all the way through labour. Now, some women will be able to continue their routine medications that they had pre-labour. If they're on labetalol, if they're on nifedipine, and actually they're labouring quickly, they can just continue these. However, there may be some women who need more than just oral medications. There may be women who their oral medications are no longer working, and we need to up these medications to intravenous. The classic one is we use labetalol, but sometimes we will use hydralazine, which can work extremely well for people who have very resistant blood pressure. Sometimes these just may be stat doses that we need to give, but some people may need an infusion of either labetalol or hydralazine. So often these women will have multiple intravenous cannulas because they're having numerous different medications. And we need to consider eclampsia prophylaxis. So anybody who has a sustained blood pressure of 160 over 110, they are much more likely to have an eclamptic fit. So together with their blood pressure management, we need to consider using magnesium sulfate, which is a loading dose followed by an infusion, and that would continue for 24 hours post-birth. Now, fluid balance, why is that so important? So it is often forgotten for some people, but actually knowing what is going in and knowing what is coming out, not necessarily with a catheter, but we should be measuring what comes out in the urine. It's because preeclampsia is associated with all their blood vessels being more leaky. And then sometimes we're giving people oxytocin, which counteracts that, so means that they're not producing so much urine, because oxytocin can act as an antidiuretic. And sometimes you will see the urine output slowly go down and worsen. And this can be a sign of their preeclampsia worsening themselves, and it may be the only sign. However, because the labour is progressing, then you have to consider, is this the baby's head that's actually compressing the bladder, making the urine not able to be to come out. So you have to consider both of these at the same time. Now, I've put on here pulmonary edema. We don't see this very much anymore. However, going back in the Embrace reports, or the CMAC reports that they used to be called, pulmonary edema was a major cause of maternal death because of preeclampsia. And that is because we used to try and give people more intravenous fluids during labour, thinking we were helping women with preeclampsia. And actually, because their blood vessels are so leaky, fluid just used to leak out into their lungs, causing their oxygen saturations go down. And actually, this could happen very quickly, and they had flash pulmonary edema. The other thing we need to think about if the urine output starts to go down is if they're on magnesium sulfate infusion, they could become toxic with excess magnesium in their bloodstream, which can slow their breathing down, reduce their reflexes. And this is why we need to watch this very closely as well with those increased observations. So a little picture just going back to the pathophysiology of what is happening in all the blood vessels during preeclampsia. Now, obviously, you're having a higher blood pressure. As you can see, the vessels themselves become more leaky, allowing proteins, which are usually trapped inside the blood vessels, but they leak into the third space, into that tissue space, which then brings out more fluid, which should be inside the blood vessels, but actually goes out into those tissue spaces, leading to the characteristic edema that you see. Now, obviously, this is people's feet, but you get that in their face, in their hands, and of course, in their lungs. So actually, these women we need to consider are fluid overloaded, but intravascularly dehydrated. And because in the vessels we thought they were dehydrated, this is why we thought it's a good thing that we give them extra fluid. But actually what happened is they became overloaded, particularly in their lungs. And this is what happened. And this is what we used to, unfortunately, lead to maternal deaths. Hence why you will see an awful lot that people with preeclampsia will be fluid restricted. Hence why we need to know exactly what is going in to all those drips, the oxytocin, the fluids, the magnesium, and we need to know what's coming out. During a labour, we need to watch for those complications. And so you will often see people having regular blood tests, even every 6 hours, which you think, goodness, that is a lot of blood tests that we need to take for these women. But what are we looking for? We are looking for deterioration of their preeclampsia and potential sequelae of the preeclampsia that could be happening. So platelets can rapidly fall in labour, which will obviously have an effect. If they fall less than 70, that woman may not be able to have regional anaesthetics. They also may have a rising creatinine, which means they're actually developing a kidney injury, which may mean their kidneys are really not working so well. We also see people becoming more encephalopathic with their liver function tests going higher and higher, which sometimes means that the liver stops working altogether, which can then affect their clotting system. They're almost going into a DIC, so they have intravascular small coagulation, tiny microclots starting to appear around their blood vessels. And in acute fatty liver, women become more hypoglycemic. Their blood sugar goes down because their liver is not working properly. And all of these can develop very quickly in labour, hence why we are doing these regular blood tests. Now, obviously, we're still looking after mum, still making sure she is coping with labour. Often we will tell people with pre-eclampsia to consider an epidural. Now, why do we do that? Obviously, it's an excellent pain relief. However, it is actually a treatment for their blood pressure. And sometimes the epidural itself will reduce the sympathetic drive to their blood vessels, which will then lower their blood pressure, therefore avoiding intravenous medication, potentially avoiding magnesium sulfate. And obviously is a good form of pain relief. We also haven't talked very much about our baby. This little baby we need to monitor a lot because sometimes, as you know, pre-eclampsia can be associated with fetal growth restriction. And actually at the start of labour, we need to consider, is this baby fit enough to go through labour? Or are we seeing a baby who's chronically hypoxic? And if we add some stress of labour and contractions, actually, we may not tolerate it. And actually, this baby may not do very well. And this is why we recommend a continuous CTG for all babies and all mums with pre-eclampsia. So what do we think about the second stage? Is there anything, we get to 10 centimetres, we're almost happy having a baby. And obviously we can aim for a spontaneous vaginal birth if all those above have been nice and stable. However, we know that women with pre-eclampsia are more likely to have an assisted birth. Now, why is this? We know in the UK, 1 in 6 babies are born with an assisted birth, either a pair of forceps or a ventouse. However, particularly in pre-eclampsia, the things we are considering, if their blood pressure is becoming more uncontrolled, which can happen with Valsalva movements when they're pushing, that can raise their blood pressure, and sometimes we will need to intervene because their blood pressure is becoming higher and higher during that second stage. And again, we talked about the importance of fluid balance. If the urine output is actually becoming really minimal, particularly if they're on magnesium sulfate, or we're really considering that actually their kidney function is starting to tail off with our rising creatinine, maybe we need to expedite delivery so we can see whether actually their rising creatinine was because of head compression or a worsening pre-eclampsia. And obviously, if it is prolonged, their second stage is over 60 minutes, often we will go in and suggest that they need intervention. And unfortunately, women with pre-eclampsia, we do have a lower threshold for an emergency caesarean section for maternal condition or also fetal condition if we're worried about that developing hypoxia. Things to consider in our third stage. We always recommend an active third stage for women with pre-eclampsia, and this is because they have an increased chance of PPH. Now, this may be because they have those slight clotting derangement which has started to happen, or their blood pressure is high enough that actually they may have a big bleed before we can control their blood pressure again. So what we would offer is intramuscular oxytocin 10 units, and we avoid ergometrin for these women because we know that ergometrin can put their blood pressure up. So symptometrin is out, ergometrin is out, and we stick to the oxytocin. What we need to consider the next 24 hours. We have a baby and everything is fine and we've done it. We've got a baby out vaginally. Aren't we doing well? Now, the next 24 hours, however, significant fluid shifts are happening. With this fluid that is going from the tissues back into the intravascular space, this can promote a difficulty with their blood pressure. And actually, their blood pressure can worsen before it starts to improve. And so we need to closely watch what their blood pressure is doing. And as we know, 40% of eclampsia happens in the postnatal period. So we need to watch for their any symptoms of the pre-eclampsia getting worse. If they have a magnesium sulfate infusion, this needs to continue for 24 hours after the baby is born. This is routine to make sure because their pre-eclampsia was severe enough that actually we will need to intervene. Sometimes we need to consider changing their medication. If they've been on oral medication, labetalol, nifedipine, sometimes they've continued that through their labour. Actually, we need to consider changing to a more reasonable once a day, twice a day dosing, which Layla is going to take you through. Importantly, we need to consider VTE because these women, intravascularly dehydrated, are more risk of having a blood clot post-birth. So considering when they need to start heparin, it's a good thing to do that early. And obviously, we need to plan for their ongoing care, their long-term health, and never forget their contraception. Thank you very much.